And good evening, all ladies and gentlemen. Thanks once again for coming back to Tea Talks, Tuesday Tea Talks. The main idea behind Tuesday Tea Talks is to create a knowledge bank from various experts so that whenever we need some information, we can get back to this information again and again. And also to clear some myths and to be akin with the current affairs that are happening. So today's guest is Haritha. Let me introduce Haritha to all of you. I'm sure many of you must already know Haritha, but still, Haritha is the chief clinical dietitian working at Apollo Hospitals, Hyderabad. She has expertise over 2 decades in field of dietetics. She is now convener for Indian Dietetic Association, Telangana chapter. To her credit, has a number of research articles published in various prestigious journals and won number of awards. And she also trains registered dietitians, and the dietitians who are trained under her have been placed in very good places, high places, I would say. And I'm sure they all of them vouch for that. That is the best training I would say, because I heard dietitians telling me. So over to Haritha. It's your time now. She's going to speak on the COVID. What is your topic? Yes. COVID is the topic. Of course, that is the current topic now. But what is your topic?
Yeah, so it's specific to nutritional management.
Actually, yes. Yeah. Nutrition care of hospitalized COVID patients in India. The main reason why Haritha is talking, I mean, she has taken this topic is she wants to let us know what is happening around India regarding the COVID patient treatment, especially for this is very good for dietitians. So please, over to Haritha.
Yeah, thank you. And the video continue. Give me 2 minutes, guys.
You can start with the slideshow and start with the beginning.
I have shared the slides. Hope you're able to see it.
Yes. Yeah. We are able to see, but go to slide. Yeah.
Yes.
So can I start?
Yes.
Yeah.
Yeah. Okay, at the outset, I'd like to thank Dr. Janaki for giving me this opportunity to interact with all of you. I think among all of us, especially in Hyderabad, Dr. Janaki is the one who takes up, the latest method of interacting and comes up with something highly innovative. I really love the name called Tuesday Talks for this session. It makes it both formal and informal at the same time. And if I see the number of people or those who have logged in, I seem to know many of you. I can see Varsha, Archana, Sumaira, and so now I feel comfortable, talking to all of you because I'm talking to one of those whom I know. This session particularly is being done only for those patients who are critically ill. That means they're admitted in the hospital. And this is not meant for those sessions which we do wherein we are talking about general immunity boosting, or we are talking about how to prevent, succumbing to a particular condition like this. So these are patients who are already admitted and are at various stages of the COVID, and what kind of intervention, nutritional intervention, can we do best to ensure that they deteriorate in their nutritional status. Mine is a short presentation. It will not take more than 30 minutes. I would love it if we have certain interactions wherein you share what you are doing at your center. How is it that you are interacting with these patients? Anything different that you are doing, and anything very innovative method of interacting with these patients is what you're already practicing is what I'd like to share. What I'd like to hear. Right now, what I'm doing is I have spoken to other colleagues of mine in various Apollo hospitals across India and try to understand how differently are we doing from one another, apart from, of course, taking information from the latest guidelines that have been presented. So I will present few guidelines. I will also present our experiences of doing it and try and put it all together to, to all of you. And then we'll have an interaction to see how differently each one of you is doing. So to begin with the session, in a review by the WHO China Joint Commission of the total number of population, that is affected by the corona, only 6.1% are classified as critically ill. That means they either have a respiratory failure, shock, or a multi-organ dysfunction or failure, and 13% as severe COVID. That means they may not have multi-organ dysfunction, but they could be having dyspnea, or they have a respiratory rate failure or increase where there is greater than 30 breaths per minute, or the oxygen saturation is less than 93% on room air. What are the common symptoms? Before I go into the nutritional management of it, I will briefly discuss few things. One is the common symptoms. Second is what is the classification of the COVID stages itself, and then how do we, how the nutritional management is going to be different in each one of them. So if you look at common symptoms, the most common symptoms, of course, are the non-specific ones where you have fever, cough, fatigue, certain breathlessness, but this could be general and this could be common to any viral infection that we have. The median time for these symptoms to develop into pneumonia is approximately about 5 days, and the symptoms where there is a specific onset of hypoxia is about 7 to 12 days, and most patients have bilateral opacities on chest and chest CT or radiographs. That means as the days goes by, there is increased hypoxia and inability to breathe or be comfortable at room air. So if you look at the global pandemic caused by severe acute respiratory syndrome, you see that there are about 5 to 10% of the infected patients requiring admission to intensive care. So we are talking about these patients who are either hospitalized or another 5 to 10% who might need intensive care. That's where your medical nutrition therapy needs to come into play aggressively from day one, so that you don't have a deteriorating nutritional status of all these patients. Now, to begin with, these patients could be slightly nutritionally at risk, because before going into the hospital, they may have had dyspnea, they may have had weakness, they may have had fever, cough, etc. And just like in any normal disease condition or any viral infection, there would be decreased appetite already. So with a decreased appetite, with a poor intake to begin with, these patients could be nutritionally at risk, especially if they're in the intensive care unit or they need a prolonged hospitalization. So therefore, at present, fighting against COVID epidemic is entering a very decisive phase, and therefore we need to be at least clear about what the nutritional management in these critically ill patients should be. Of course, this is not as clear cut as in many other conditions. When we're talking about cardiac, diabetic, or hypertension, there are plenty of guidelines available, and the dietetic community in each one of you is absolutely clear about what the guidelines are, how do you implement, what the challenges are. However, this is a beginning that we are making in trying to understand how nutritional management of COVID patients in a critical care unit is going to be slightly different from what we routinely see in the regular intensive care unit. Now, many of us might argue that they are just like any other critical care unit patient. They are just like any other patient who's having ARDS. Many of the commonalities might be there, but we need to understand how these COVID patients are going to be slightly different. How and when, what are the challenges that we are going to have in terms of managing them, because outreach is so difficult, And then fine-tune our nutritional management. If you're already in a hospital situation, you know very well what you're doing, what you need to do for a critically ill patient. We've gone through that many times. However, you need to know the finer nuances of how the corona patient is going to be differently handled, or what are the challenges that he's going to have during the hospital's stay. So before that, I briefly discussed the different stages and characteristics of a COVID-19 patient. It presents itself as a multi-stage syndrome. So that means it progresses from one stage to another, and we need to identify what kind of a patient are we dealing with, or the patient that we are dealing with is in which stage of the condition. Based on that, the nutritional interventions could be very, very different, or our decision making could be entirely different. These classifications are based on the WHO classifications published in February 2020. You have stage 1, which is an uncomplicated illness where the patient has upper respiratory tract and infection and may have any kind of a non-specific symptom like a fever, cough, sore throat, etc. And these patients do not have any signs of dehydration, sepsis, or shortness of breath. This is the first stage of the classification where it is completely uncomplicated. Then you have stage 1 of pneumonia, where patients has signs of pneumonia but no signs of severe pneumonia. Non-severe pneumonia has cough or difficulty in breathing, or they may be fast breathing, but nothing really beyond that. The second stage of pneumonia, where there is fever or suspected respiratory infection, plus one of the conditions where the respiratory rate is greater than 30 breaths per minute. There is severe respiratory distress where he's not comfortable on room air, and the oxygenation is less than 90% on room air. So this is the stage 3 or severe pneumonia, where definitely there is a compromised intake, and we need to seriously begin looking at how we can supplement the person. Then there is a stage 4 is ARDS, that is acute respiratory distress syndrome, where there is onset of new or worsening respiratory systems within a week of the clinical insult. And we can see that chest imaging, or there are opacities with chest imaging, CT scan, or the lung ultrasounds that have been done. Sometimes, if it is too late, the patient could present in stage 5, where he is already septic, and it could be there could be a life-threatening organ dysfunction caused by a dysregulated host response to the suspected infection or a proven infection with specific organ dysfunction. So the signs of organ dysfunction is something that all of you know, where there could be altered mental status, difficulty of fast breathing, there's a low oxygen saturation, weak pulse, low blood pressures, acidosis, etc., which is evident on the lab parameters as well. The last stage is, of course, septic shock, where survival itself and it could be an issue, and mortality could be high, where there is persistent hypotension despite volume resuscitation, and the patient might need vasopressors to maintain the mean arterial pressure above 65 and the serum lactate levels above 2 millivolts per liter. So you could get, so these are the 6 stages, and we could receive or be seeing a patient in any of the 6 stages. Based on which patient you're seeing and which stage he is in, we can either induce an aggressive nutritional therapy, or sometimes we have to hold back and think and decide, like in septic shock, whether we can feed the patient at all or not. While we always need to focus on early entry nutrition, if the patient happens to present themselves in a condition of septic shock, that's when we need to hold, decide, wait, and see whether feeding them could be counterproductive. Let's briefly understand what is a nutritional metabolism which is going haywire in these patients. If you look at the nutritional metabolism in all these patients, you will see that there is reduced glucose oxidation, increased glycolysis. Because of increased glycolysis, there is enhanced gluconeogenesis and insulin resistance, all of which contribute to increased blood sugar. And any high blood sugar is an excellent medium for the virus to grow, and therefore could be very, very difficult to contain. And we've all been advising all our patients to have excellent blood glucose levels to begin with, because if you have a patient presenting with sugars of 300, 400, where they have been uncontrolled to begin with, and if they land up in a situation where they're critically ill, it becomes extremely difficult to manage these patients, where the virus can grow incessantly. There is also increased protein breakdown, increased protein synthesis, and more importantly, there could be a change in the amino acid spectrum. That means there could be a decrease in the branch chain amino acid concentrations, increased fat mobilization and decomposition. So as the branch chain amino acid requirements go up, they could be at the same time being drawn away because of the increased protein catabolism that we see. All of this could cause malnutrition, which we are very well aware of. And the main causes of malnutrition, while they remain the same as in the critically ill, there could also be additional concerns of increased energy consumption simply because of fever, increased work of the breathing muscle, and mechanical ventilations. All of these further contributes to increased energy demands. There would be metabolic disorders. There is impaired glucose utilization and tolerance. There is a lot of insulin resistance that you will see. There is protein and fat breakdown, just like in a critically ill patients, and a negative nitrogen balance in the body. If you look at the further causes of malnutrition, of course, insufficient intake and malabsorption of nutrients could be there. There is dyspnea, there is insufficient appetite, very poor appetite, and that does cause a long-term, that does have a long-term impact on intake. Apart from that, we also see that the corona can attack the gastrointestinal tract in a small percentage of population. Among the 10% or 15% who need to get admitted to a critical care unit, among them only a small percentage, that means about 4% of them, could have a direct attack on the GI tract, where they experience various symptoms like nausea, vomiting, diarrhea, inability to tolerate enteral feed, so on and so forth, all of which contribute to increased loss of nutrition. There could also be certain unique symptoms which are specific to this condition. So we need to identify and differentiate these unique symptoms. One of them is loss of taste and smell. You must have already read and heard that some of these COVID patients do not have cough, cold, fever, but they present as loss of taste and smell and GI symptoms in around 10% of the cases. That means that could be the presenting symptom, and if the physician in the first level does not pick that as a symptom, the patient could go into an advanced stage of the disease. Then there are these are coupled, of course, with nutrition impacting symptoms typical of critical care, where there is respiratory illness, extreme fatigue, dry mouth, and of course loss of appetite. If you look at what other additional operational barriers are there. There are a lot of operational barriers. Though these patients behave so much like the critical care, we do not have access to these patients as much as any other critical care patient. And therefore, there are a lot of operational barriers to oral intake, which may impact menu selection, limitations with meal delivery. I'm sure all of you working in the hospital agree that not only the dietitian but the service team is also having highly limited access, and therefore a lot of food gets delivered at a time to these wards, so that they're not that repeated number of visits to that unit. Feeding assistance is poor because we may not be having that kind of a nursing care, which is very common in a critical care unit. due to fewer nursing staff, restrictions on family visitations where the family cannot assist the patient and the patient has to feed himself. And we're seeing this so much in the hospital that though food is provided, though there is a timely intervention and every second hourly you're able to provide food to the patient, patient is unable to feed themselves, and this itself causes a lot of anxiety, depression, which kind of further adds to the inability to eat or decreased nutritional intake. Apart from that, the need to conduct a dietetic consult, mostly done remotely, and less frequent reviews due to staffing levels. Because of the operational limitations and the decreased utilization of PPE that we need to do and less amount of exposure, we are not seeing these patients on a direct level. We are seeing them quite remotely. This definitely decreases the ability to review them, ability to understand what they are eating. We have to depend on other staff, the doctor level or the nursing level staff, to understand what is the actual intake of the patient. And while information gets communicated from one level to another, there is limited information which we get to understand what is the actual intake of the patient and whether we need to intervene and at what time we need to intervene. So what is the impact of this malnutrition? While we broadly understand malnutrition in these critically ill corona patients will not only, will primarily reduce their respiratory muscle function. We need to build that, and the malnutrition's first impact could be a weakened respiratory muscle function and the weakness, but also aggravated immune dysfunction. We all are aware that immunity is affected. It may not be the day 1, day 2, day 3, and we may not be able to really improve the patient's immunity during hospitalization. But yes, we need to at least understand that the nutritional status does not deteriorate during hospitalization, and we are at least able to maintain with the good immunity what he has come in with. Therefore, carrying out, keeping all this scenario in mind, in spite of the limitations, it is important to carry out a reasonable nutritional assessment and to prevent what kind of malnutrition deterioration that can happen. Now, even within our own system, we find that nutritional assessment, as we would do to any other patient, is limited. However, we are able to do a lot of televisits. We have complete access to these patients in terms of our televisits, and therefore can speak to a lot of them multiple number of times, trying to understand what they need, how they need, and this also gives us an opportunity to assess their actual intake and then supplement if required. So let us now, with that background of classification and with that background of understanding that they could be having some specialized unique symptoms which are very different, and given the conditions and given the physical limitations with which we have to see and assess these patients, let us now try and understand what are the general guidelines which have been advocated for these patients. These guidelines which I am referring to are the recent ESPN expert statements and practical guidelines given away in March 2020. How do you do screening, whether screening at all is possible, whether it is done by a dietitian or it is done by a medical professional. Weights are difficult to obtain, heights are difficult to obtain. The nursing also does not want to have so many number of interactions with the patient. So the only way is if the patient is conscious, you kind of check with them and they might know, but there will be limited screening opportunities. However, as much nutritional assessment is important because that gives us a starting point based on which we will be able to intervene as much correctly as possible. With limited PPE supply, many dietitians are actually not allowed to enter the ICUs or patient rooms or patients in isolation, and are not therefore able to perform a nutrition-focused physical examination for sure, but rather rely on other providers to collect physical data on these patients. And this is, I think, pretty much universal. This is what is happening in all the centers which are taking the COVID patients, where you rely on the minimal nursing and medical staff which are there to give us the required information based on which we can document the nutritional status to begin with. Telehealth visits is strongly advised even by the ESPN, where dietitians use other means to collect assessment data, including calling the patient or family, using virtual and telephonic visits, including various platforms like audio and visual. I think this is what is very clearly suggested by the guidelines, and this is pretty much what is happening across the board in being able to interact with the patient. So it's not a blind way of creating a nutritional management plan, but it is at least partially there by doing a teleconsult, which seems to be very, very comfortable and far more easier to do. And therefore, once you have these assessments done, documenting them is easy. You may not be documenting them in your traditional way of doing so, but some method of documenting where you document and keep it with you. You're not able to put it in the file, or you do create your own Excel sheets on the system and document that, but some documentation so that as you hand over, you know that you're giving away the right written information to the next team which is taking over. Let us look at the energy targets, how much energy, whether it is any different or not. Now, when you're looking at determining energy requirements or caloric needs for critically ill patients, it is globally accepted that you do the right method of doing it is to do it through the indirect calorimetry, where you use a metabolic cart and do it. However, because of the limited number of invasive procedures that you should do, and you should do a procedure only if it is absolutely necessary, and the frontline medical resources for the rescue of these patients are scarce, it is currently therefore recommended by ESPN that it is not applicable that you do it through indirect calorimetry, and therefore can use predictive equations to do so. So in India, of course, still we are based a lot on predictive equations or the 25 to 30 kilocalories per kg ideal body weight, and that's, I think, directly applicable and more applicable now to these set of patients. If you look at let's try and understand the target amount of protein that we need to give. Not only the total amount, but what kind of protein that we need to give. Normally about 15% is enough, but you should try and improve the energy supply ratio of protein to about from 15% to 25%, and if possible about 30% of the total energy requirement. So if you look at therefore it kind of comes down to 1.2 to 2 grams per kg in non-obese patients. If the patient is extremely obese, you can go from 2 to 2.5 grams per kg of the ideal body weight to ensure that the sarcopenia does not set in. But if you look at, that is the total quantity of protein. But if you're looking at the type of protein that you want to give and what is the kind that you want to focus on, they recommend that increasing the supply of high quality protein, specifically BCA, branched chain amino acids, is recommended, and therefore high quality proteins such as whey and other animal proteins to be increased to almost about 50%, wherein you get more quantity and also you get more easily assimilable form. Is more beneficial to prevent muscle loss, and it would help the patient to get out of the bed and enhance the strength of the respiratory muscles. How much of BCA should be given? It is recommended to supplement BCA to 30% of the total protein quantity, which can not only significantly inhibit muscle breakdown, can also try and prevent insulin resistance to some extent. So focusing on BCA is important, whether it is through the regular diet or through supplementation if you choose to do so. Target amount of fat remains pretty much the same, where you reach out to 25 to 30% of the total calories coming from fat. EPA enhanced diets will be of significant value because they are known to decrease inflammation. Quantities of about 2 grams per day is what is known to have the required health benefits, and therefore whether you're giving it in the form of the regular diet or a supplementation which has enhanced EPA quantity is something that could be a decision that you take then and there. Fats in the form, another word of caution here is fats in the form of PN, if at all, if need to be given, should not be over enthusiastic, because now in the market we get only lipid emulsions. So where the patient is unable to have the regular caloric intake, supplementing with parenteral nutrition, especially only fat, or giving TPNs which have increased quantity of lipids in them should be prevented, as there is a possibility of increased hypertriglyceridemia or abnormal liver function. So you could use a triple chamber bag, but you need to keep your eye and assess your triglyceride values and your liver functions before you initiate the TPN, especially if it's going to be for long term. Liquid volumes could be limited, where the general principle of fluid therapy to stabilize a patient remains at 30 to 40 ml per kg per day. Most patients have pulmonary edema and fluid accumulation. So we need to bear in our mind that while patient is not able to tolerate a solid diet, we cannot overload the patient with too many fluids, and we need to look into the fact whether at all, or ask for the fact whether liquid volumes, how much can be the liquid volumes, whether patient has edema or any kind of a fluid accumulation, and making the balance as much as possible. What about the micronutrients? Are they any different? These patients should get a conventional multiple micronutrient supplementation like all our critically ill patients, but we can focus on B1, vitamin C, selenium, zinc, and ensure that at least they are taking that much value as it is normally recommended in our RDIs.
Right.
Most of our diet, we see that if you don't focus on C, if you don't focus on the zinc, if you don't focus on the B1s, even the normal recommended values may not be there. So this is all that they are saying is that the baseline requirement of these specific nutrients need to be looked into and ensure that the diet is providing. Vitamin
D.
Yeah, I thought I had one slide. Vitamin C. Many studies in the recent years show that a higher dose of vitamin C given intravenously could significantly reduce mortality in these patients, or at least shorten the use of booster drugs and mechanical ventilation. And therefore the need to at least look into what we are giving, whether we can give an enhanced value or not, and if applicable and agreed upon, try this method. Now, where does the research come from? There's a lot of Chinese papers which very clearly recommend that. From many such papers, the ESPN has also picked it and does recommend vitamin C in higher intravenous doses. Vitamin D, I think all of us, when we are looking at immune boosters, or we are looking at patients who are far more susceptible than the regular, than each other, we all know already that vitamin D is a big player in terms of regular normal immunity. And there is a connection very clearly seen in certain countries where vitamin D is very low because of the climate, very cold climates that they have. And the correlations have come out in certain European studies where they say that lower the vitamin D, higher the susceptibility. And while we are talking about that in general immune boosting diets, we also need to assess and evaluate, if possible, the vitamin D status. And since anyway, most of the population, even in a tropical country like India, we see that every other patient is low on vitamin D. Specifically looking for this nutrient in these patients and giving them the higher value and giving them a large booster doses would be applicable. I'm moving on to the last part of the presentation, where I'm looking at, I'm just discussing nutritional management on different stages of COVID. You have the uncomplicated illness where the patient is having breathlessness, cough, sore throat, etc. Here we just have to ensure that the patient is eating well, with adequate nutrition, both on macro and micronutrients. We could give it in the form of liquids and soft diets as acceptable. We have to ensure that hydration is good and adequate. And if the disease progresses in severity, then only we are expecting an intestinal dysfunction. When there is mild and moderate pneumonia, we know that eating difficulties will arise, and there will be a challenge in meeting the caloric and the protein requirements as well as the micronutrient requirements. In this stage of the patient.
1 second, Harita, can you keep your mic a little closer? Voice is breaking in between.
Okay. Is this any better?
Yeah, much better. Yeah,
okay.
Thank you.
I'm just too close to the camera. Okay. So if the pneumonia is already in mild and moderate stages, we can very clearly expect that there will be a limitation in the intake, and this would be the right point to consider using a nutritional supplement. While I say this, I spoke to my counterparts, Ms. Babita in Calcutta, where they are dealing with a lot more number of COVID patients. They have a good process where once they assess that the intake is very, very limited, they're automatically supplementing, starting with an ONS supplement where it provides around 300 to 400 calories. So they know that at least, some part of it or 1/4 of the requirement is actually met. And this is pretty much what is being suggested in the guidelines as well, where you consider a nutritional supplement which is slightly higher in calories, preferably the one without any added sugars, especially in pediatric patients where malnutrition could set in just like that. They've suggested that how much ONS to use is another question. There is so much of fear of using too many scoops. Most Indian mentality, we have got used to that 2 scoops in milk once a day, twice a day, or at the most give that as TID. But our outlook should be on how much of calories should come from, or how much of the total calories, or how much of the total proteins should come from the ONS. So if you have, let's say, a 1600 calorie diet, 1/4 of it would be 400, and we should see at least 1/4, if the patient is eating some amount of solid diet, 1/4 of the calories do come from the ONS. So it should provide at least 400 calories and try and include 30 grams or more of protein per day coming from there, so that we do not have to worry about that part of the requirement. Then we have patients who are in the severe pneumonia and ARDS stage, where oral feeding could be difficult. It could be continued if the patient is comfortable and support with an ONS, preferably without added sugars, but proactive enteral feeding could be started at this stage. So what is that? Proactive enteral feeding could be started at this stage, especially when we see that the intakes are far less than 40% of their actual needs. ARDS patients where there is a frank diagnosis, they should be started on enteral feeds. Post-pyrolic feeds could be initiated if at all there is GRD and if the risk of aspiration and severe cough. In the sense, we know that these are the patients who could be at risk of aspirations. These are the ones who could be coughing incessantly and therefore could be candidates for aspiration, and therefore right at the beginning consider post-pyrolic feeding. Like all our critical care, early EN is indicated, that is in the first 48 hours of admission in ICU. However, the calorie density should start very slowly. I have seen a couple of presentations where almost everybody is recommending a 2 kilocalorie per ml kind of supplementation. However, we need to be very cautious in going that way and walking that road and being too aggressive in feeding them, or not only because of the risk of aspiration, but also in terms of tolerance. And therefore, initiating calorie infusion at 15 to 20 kilocalories, and then going up to 20 to 25 and to 30 kilocalories over a period of 2 to 4 days is what is recommended. When the patient is in sepsis or in kind of a septic shock, that is a stage 5 and 6, there could be acute kidney injury, and there could be needing continuous hemofiltrations. In such patients, protein needs need to be raised to 1.3 to 2 grams, and you need to evaluate if the patient is on renal replacement, which could lead to further micronutrient losses, and these need to be replaced. Gastrointestinal dysfunction could be very evident and present in patients with sepsis and septic shock. There could be diarrhea, there could be impending liver failure, and in case of an edematous bowel, enteral feeding there could be a need to curtail the enteral feeding. But this decision is that moment decision, that day's decision based on the symptoms that the patient is having. While these patients are highly susceptible to malnutrition, the ESPN guidelines recommend that you start off with hypocaloric nutrition, which is below 70% of their estimated needs, should be preferred over isocaloric nutrition for the first week of an ICU stay. The goal is to go to isocaloric within the first week. Don't be too aggressive is what the recommendation is. Patients with, however, patients with COVID who are often sick at home for days to weeks together prior to being admitted could already be at risk, and therefore, based on your assessment, you could decide whether you want to go full strength. Enteral nutrition, yes, of course, is recommended. Even if you are not able to give full strength, you want to keep the favorable physiological response of keeping the intestinal mucosa patent. You do not allow the leakage, you do not allow the cracking, which could further aggravate the sepsis. And you want to keep the intestinal mucosa bathed with basic nutrients so that you don't have translocation. Mode of enteral feeding is something that we need to decide on. It's very clear, evident, and convenient to do continuous rather than bolus ES, which is again strongly recommended and is supported by various associations like the ESPN and the Society of Critical Care Medicine and ASPEN. Multiple meta-analyses have also shown a significant reduction in diarrhea. They don't say that outcome parameters get better from bolus to continuous, and if you switch the patient to continuous, you're going to have a miraculous recovery. No, but they say that there is an incidence, decreased reduction in diarrhea incidence, and also tolerance could be better. But in these patients of COVID, where you want to have limited number of visits, even of the nursing staff, I think continuous rather than bolus is definitely the way to go forward. We are seeing that doctors are automatically switching to the continuous mode of feeding, where about 6 to 8 hours, once you set the feeding pump, there is no need to really think or bother about feeding. This definitely reduces the burden of the nursing staff. You can also, we can also think at this point of time about ready to hang feeds, where you attach and the feed volume that you want per day goes continuously to the patient without any hindrance. So there is minimal contact. Even feed preparation is not happening. Direct ready to hang bags are bought and attached to the infusion pump. These are available in India now, and we could look at the possibility of using them. Now, in addition, since bolus EN delivery require more frequent interactions, continuous is preferred. Another thought process or suggestion that is coming forward from ESPN is if the patient room allows for a pump to be placed outside the room, that's great, so that the nurse can look at it, the medical team can monitor, and required adjustments can be done from outside itself without having to increase the number of visits. Another word definitely on the intestinal motility we know that this could be a concern, especially in COVID patients, and the fact that we know should make us more alert and look for these symptoms far more quickly than when they're evidently present. Almost 4% of the critically ill COVID patients with intestinal dysmotility have clear evidence of small or large bowel ischemia, and therefore appears that intolerance to enteral feeds may be exacerbated by significant GI involvement. And if we see a slight possibility of that, if that gets reported, it is therefore the right thing to do to stop giving EN, where EN gets contraindicated. While we know that early EN is important, small trickle feeds are important in almost all critically ill patients, we should also know when EN gets contraindicated. So if you have presented with gross intestinal symptoms, you need to know that this is a signal for us to stop EN, or where it is contraindicated, or you slow down the entire feeding pattern that you may be following. So early EN therefore may not be preferential in a subset of patients with COVID with specific GI involvement, and we need to identify them. And these patients, you won't be aggressive. You're not talking about early EN. You're not talking about progressing to fuller feed volumes in the first 3-4 days, and so on and so forth. Before the onset of respiratory symptoms, some patients, as I said earlier, might present with diarrhea, nausea, vomiting, or sometimes a gastrointestinal bleed. While the medical team will look into this, we can also include them as part of our assessment so that it helps us catch these symptoms early and accordingly modify or decrease the amount of EN that we may be giving to these patients. One word on formula selection and tolerance. The recommendation is very clear that you give a regular isotonic enteral formula, which should be used in the early acute phase. When we use a hypercaloric formula, I have seen that a lot of youngsters would be jumping to use the hypercaloric formula because that is very exciting to use, where you can provide almost 20 to 30 grams of protein at one shot, or you can give double the calories as per the volume. However, while these are available, 3 out of 4 nutrition guidelines provide recommendations that you can go up to 1.2 kilocalorie, 1.5 kilocalorie, but go a little slow for your volume controls, but go a little slow on your hypercaloric formulas. So concentrated formula use should be highly specified and is actually not recommended due to the increased osmolarity and higher fat content, which would most likely exacerbate delayed gastric emptying. So I'm coming to the last but one slide where I'm putting it all together in terms of the 5-step treatment of malnutrition, wherein each step of nutrition intervention is what we need to implement. That means we need to see which of these combinations is right based on what characteristics, symptoms, and which stage that the patient is in. The first one, of course, would be diet plus nutrition education, where you provide the diet, educate the patient, and reassure the patient that this would be the right thing for them, and encourage them to have in whatever small quantities that they are able to have. Reassurance goes a long way, and therefore they feel much comfortable that somebody is talking to them about the food specifications, and they're absolutely ready to listen at this point of time. Second step of treatment could be the diet plus oral nutrition supplement, which could give you about 1/4. I mean, the goal should be that 1/4 of the total requirement should come from ONS, not the total requirement. But if you have a patient on liquid diet and you see that even liquids intake is getting difficult for them, especially oral liquids, there you could plan about 50% of the calories coming from your oral nutrition supplementation. That's third, of course, is your total enteral nutrition, where you go stepwise. You initiate give trickle feeds, see the tolerance, and escalate up to the total requirement. But the goal, as they mentioned, should be less than 70% and should be slightly hypocaloric at least for the first 1 week. The fourth, of course, is the parenteral nutrition if the EN is contraindicated, and you could do partial or total parenteral nutrition. When your EN cannot supplement the total needs, TPN, nutrition support in the form of TPN is required, and the total energy targets of about 60% of the total energy targets can be met by TPN, and we need not be over aggressive, at least for the first 3 to